and we compare that to the tafamidis phase 3 study, and it looks like diflunisal is better than tafamidis. And so we're just trying to see, okay, how does tafamidis and diflunisal compare to imotersen and patisiran? And then if you had a super potent stabilizer or a super potent knockdown, like the next generation, which one is mechanistically going to make more sense? And I mean, in our mind, it actually gets quite comparable because you're trying to reduce that monomer concentration.
Right. I mean, I think you guys are asking really good questions. So first, you can't really compare the John Burke diflunisal study, right? Because it's really only in peripheral neuropathy done.
Yeah.
Right? It's only neuropathy. I mean, I think they actually excluded cardiac patients. I think they might be doing a study right now, a single labeled diflunisal study, a single center diflunisal study. But I think that from a sort of scientific perspective, you would think that knockdown should accomplish, right, what it's supposed to accomplish. But I think what you pointed out to me is the concern about the cardiac deaths. So we're talking only about cardiac patients with cardiac amyloidosis.
Yeah, but there's just fewer trials there. Like when you at the very beginning, which is obviously true, is that there's not that many trials yet in the cardiac population.
Right.
Data, so.
And that's why
we're looking at
that's why I keep going back to tafamidis. That's the only reason why I'm going to it. I haven't seen the tafamidis data. I mean, I just know as much as you've done what Pfizer's released on that web page.
Yeah, I mean, so and I'd actually love to dig into that a little bit, and I know you don't know any details, but just kind of your expectations. But first, I mean, the thing that we're trying to do is look at the polyneuropathy, because fundamentally it's a similar mechanism. I mean, yes, the phenotype is very different, but you would think that things that work in polyneuropathy patients, excluding maybe these safety challenges, might work similarly in the cardiomyopathy side. So
absolutely not. Absolutely, I would completely disagree. I mean, I think your argument would be, I guess you could say it's a cell, one's a neuron and one's a cardiac myocyte. Why would it be any different, right? But I think you can say, well, we're talking about knocking it. You know, I mean, I think you've been talking to neurologists. I mean, the argument would, then I would say, why would you have the side effects that you have? Why would you have a cardiac side effect and not it's hard for me to sort of say, well, that's what I think the companies would want you to say, right? So that you can use it and, you know, what's the difference? We have a group of patients that had a cardiac phenotype and, I mean, if you look at it up front, it didn't seem it was any worse or no different. I think we've seen that where we've seen improvement in one doesn't translate into improvement in other, and that's why the FDA is asking people to look at this. Although maybe the Europeans are saying, I don't know all the data, but
but we just saw the labels, right? The European labels were for polyneuropathy only, right? They didn't give them the broad label to include cardiomyopathy patients too.
And I think in the U.S., I don't know if the FDA has changed now going forward, but people are really sticklers of approving something specifically for what they've been studied for. Forgive me, patisiran has not been approved yet by the FDA, or have they? I don't know.
No,
it hasn't.
It's like next week. It's next week. That's why. That's one of the reasons why we're chatting right now.
Oh, okay.
Yes, it's the 11th is the date.
Right. So I can't speak for the FDA right now because things are like a little like some of us. But I think at least with cardiology drugs, and I don't know, you guys have obviously a bigger area, say when you look at cancer drugs and rare disease drugs, do people approve for things that are beyond what it's been shown for? And I think if it's a cardiac indication, they're very strict about what the study. If it was only a neuropathy endpoint, then that's what they're going to be. I would be surprised, especially now that you've also pointed out to supplement me for the patisiran. I would be surprised if it was approved for anything beyond just a neuropathy, polyneuropathy phenotype.
Yeah. I think. I mean, that's our guess as well. I mean, it a little bit depends on. I mean, it's not being reviewed by the cardiorenal division, so it's.
Really?
It's the
That's
the Office of
Who's
Neurological
reviewing
Products.
It's going to be reviewed by oncology?
No, the Office of Neurological Products, right? Because it's the polyneuropathy group primarily.
But how can, and I don't know this, how can a neurological group say you can have a cardiac indication? I don't know. It'll be interesting. You know this